Welcome to week 5, everyone. I'm Mrs. J, the curriculum developer here at AMCI, and I am thrilled to kick off another powerful week of coding mastery. Last week, we crushed chapters 4 and 6, endocrine and nervous system guidelines respectively, and you all did what forensic coders do. You learned how to break down those guidelines and figure out the correct code. Now, let's turn our attention to week 5. And in week 5, we're going to discuss circulatory system guideline. And I'm going to tell you, if I had to say the most heavily referenced chapter in ICD-10-CM on these medical coding exams, I would say it comes from the circulatory system. Yes, and today we're going to break down those guidelines, and it's going to be easy peasy lemon squeezy. I'm pretty confident. Let me know on the survey at the end. I want to know. Okay, before we go any further, let's go ahead and say hello to the baddest instructional team on the planet, medical coding instructional team on the planet. Please say hello to my team. They are in the chat. They are waving. Please and thank you. And let's not forget our interns. They are wearing the blue badges. They are the backbone of AMCI, and they keep things running smoothly during these sessions, during classes. So please say hello to the interns. Now, let's keep this energy high and the codes accurate, coders. And shout out to you as we move on to week 5, chapter 9, circulatory. Now, we can't go too far before answering these questions. We do have most commonly asked questions, and here they are. Number 1, how do I get started? 2, why did you skip some instruction? Like we did endocrine, we skipped over mental health, we did nervous, we skipped over eye. How come? All right, I'll answer that. Also, can I be in I2MC and the YouTube course at the same time? And for how to join Discord. You have questions, we have answers. Okay, coders. First question, how to get started. You just go to the website, www.amcicoding.com/YouTube course, or just go to amcicoding.com and click the tab at the top that says YouTube course. Follow those instructions and you can't go wrong. Number 2, why did you skip some instruction? Well, we skipped some of the instruction because this is a self-study course. We don't have enough time to go over all of the content, but we did make an effort to bridge those subjects that are more complex, and have the most coding guidelines and nuances. So we walked you through the more complex so that you can tackle those other subjects on your own, because you do have the tools. You can do it and you will. All right. Number 3, can I be in both I2MC and YouTube course? Well, initially the mindset was that you should have finished I2MC, then come on to YouTube course, and then we gave you some videos to watch, some prerequisite videos to watch. So to answer the question, yes, as long as you've completed the I2MC portion, and then there's going to be another portion when we get to CPT, you should have completed introduction to CPT. So yes, you can be in both. It's a lot of work, but that's your choice, and we're here to accommodate you. Final question, how to join Discord. Okay, go to the YouTube channel and you can click on any video, probably this one, the lecture below this lecture, and you'll see that join button, that black join button. Click on it and there you go. Now, after you follow the prompts to get enrolled, then make sure you link your YouTube channel after you get in the Discord. Say link. So you can link whichever channels you want. So make sure you do it and use the same email address so they know that you've paid for the Discord. All right? Now, books. Just a reminder, for the first 8 weeks of this class, ICD-10-CM is required. If you, we do prefer the ICD-10-CM expert for hospitals. If you are going to move on and take your CCS, we recommend it because it has great indicators. Also, your textbook, sorry about that. Your textbook is by Bucks. The 2025 step-by-step is recommended, although you can save money and get a later year. Don't go beyond 2023. And finally, the MCG manual that the image is 2025, but you can get the 2024 if you want to save money. All right. Now, time for the copyright. CPT is copyright of 2025 AMA. All rights are reserved. Keyword concept, FTR, Chun, AMCI Fab 7, AMCI, ICD-10-CM Flip Tap, and MCG are registered trademarks of AMCI. CPC, CRC, COC, CPMA, CPB, CPP, MCPCO are owned by AAPC. CCA, CCS, CCS-P, RHIA, RHIT are owned by AHIMA, and AMCI does not own the rights to these credentials. Hey, future world-class coders, I need your assistance. If you are loving this free course, don't keep it to yourself. Share it far and wide. Post about it. Let people know about this free course. While this course won't go away, the instructors will after the 16 weeks. So let everyone know. And think about it. The more you share or engage our course and our lectures, the more free programs we can develop because we know you love it. Right? So don't keep this as your little secret. Keeping it as your little secret could possibly make it go away. All right, so get it out there. Let's flood the world. Yes, let's flood the world with ethical, forensic, and certified coders. Okay, coders, I thank you in advance. Oh, by the way, while you're here, go down and like this lecture. However, if you want to wait until after, wait until after. Okay, now let's talk about the goals of the presentation. Goal number 1, we're going to review Section 1, Chapter 9, Circulatory Guidelines. Number 2, practice exercises to test our knowledge. And 3, we'll bring you one step closer to guideline mastery. Section 1, Chapter 9, Circulatory System. The key word is circulation. You will come to learn that all of the diagnoses and guidelines are pertinent to the circulatory system, from hypertension, coronary artery disease, cerebrovascular accidents, CVA or strokes, to myocardial infarctions. It all comes back to the flow of blood. I just thought I would say that. Now, let's talk. The circulatory system is basically your body's delivery and clean-up service. Your circulatory system moves blood through your heart and blood vessels to carry oxygen and nutrients to the rest of the body. Now, lack of circulation can cause the body part some problems. You could actually lose function of that body part or lose the body part altogether. Now, let's not even talk about the heart and the circulatory system. Let's talk about how other parts of the body need that or requires that circulation. Think about it. People lose their limbs due to lack of circulation. So this circulatory system, which comprises the heart, let me see if I have a pointer here. Yeah, I've got one. Let me see. I hope you can see it. I don't think so. I'm going to change the color. Maybe. I don't know. But the heart, and then the red tubes. Oh, I'm turning them blue. But the red tubes are your arteries, and the blue tubes are veins. Now, just so you know, the arteries are critical in moving the blood throughout your body and giving the body what it needs. And the veins, it does the reverse. It removes the impurities back to the heart, to the lungs, to get deoxygenated, right? So that blood will become deoxygenated or cleansed, and then it goes back into the cycle again. It repeats the process. So it is a circulatory system. Actually, it is, right? Now, let's get back to our discussion and let's talk about these diagnoses that we'll need to code for in the circulatory system. And we're going to begin with hypertension. And just so you know, hypertension is fundamentally a circulatory condition, and hypertension results from increased resistance within the blood vessel. And when I'm saying vessel, I'm talking about arteries, which forces the heart to pump harder to circulate blood. And over time, this chronic high pressure damages the vascular walls, right? And it affects the entire circulatory system. And that could include the heart, brain, kidneys, eyes, and more. So when we think about hypertension and as it relates to circulation, let's think about those arteries. And let's think about these arteries and let's regard them as pipes. The pipes, the pressure is turned off in the pipes. So it's making that heart work harder. Another condition caused by circulation or lack thereof is ischemic heart disease. And this is when the arteries become clogged due to atherosclerosis. And essentially, it reduces the blood flow to the heart. And if you look at the image, I know I don't have a good this pointer, I'm on a different computer. But anyway, this image right here, you can see the yellow. This is plaque or hardening of the arteries. And what causes this? High cholesterol, smoking, poor diet, exercise, lack of exercise, and hypertension. Yes, hypertension. So when we think of ischemic heart diseases, think of hardening of the arteries or those pipes that we were talking about are narrowing, and blood is unable to circulate to the heart. I'm going to let that marinate. And we have another condition caused by lack of circulation. In fact, this condition is a consequence of lack of circulation. So if you look at this heart, this represents an acute myocardial infarction or a heart attack. This is acute or active injury to the heart muscle. So because of the lack of blood circulation to the heart, just like the other parts of the body, when it lacks circulation, this could either damage the tissue or that tissue could die altogether. So this is our most vital organ, and this is very, very important, right? So this is not due to, well, this is due to lack of circulation, but more so, this condition is a consequence of the blood's inability to circulate to the heart. In other words, those pipes are completely, almost closed. Now here's another circumstance or consequence. Another consequence of the blood's inability to circulate to the brain. And when that happens, you could have cerebral vascular accidents, TIAs, or strokes. We're going to call them strokes, right? So yeah, this all boils down to circulation problems. Now let's begin the guidelines for the circulatory system. Guideline IC9A, and this guideline is for hypertension. All right, so when you're coding for hypertension, this is hypertension without any other involvement from the heart or kidneys. Essentially, I like to say this is the general hypertension code. You're going to code I-10. So when there are no other illnesses, I-10. And this hypertension is also referred to as accelerated hypertension, benign, essential, idiopathic, malignant, systemic. These are all I-10. And remember, it is presumed when hypertension is also coded in the setting of heart failure or heart disease and CKD, it is presumed that they are related, and we're going to talk about them very shortly. Also, remember that when it is related to heart failure and CKD, there are combination codes. So if you look in this column 1, you can see the combination codes, I-11, I-12, and I-13. We're going to talk about them very shortly, but just know they exist. Also, remember, when there is no relationship between hypertension, heart failure, heart disease, and CKD, then you have to code each separately. And make sure you sequence the reason for the encounter first. Okay, let's move on. Let's continue talking about hypertension. Now, when that high blood pressure makes the heart work harder to pump blood against increased resistance, over time, that strain can cause left ventricular failure, right? Or left ventricular hypertrophy, and ultimately lead to heart failure. And that's pretty much how hypertension progresses into hypertensive heart disease. So guideline IC9A1, hypertension and heart disease and or failure. So hypertensive heart disease or failure. And the combination code for when a patient is diagnosed with hypertension and heart disease or hypertensive heart disease is I-11, right? And you're going to code first I-11. You're going to code second if the patient is diagnosed with heart failure. You're going to sequence that heart failure code next from the I-50 category, or you're going to sequence I-51.4, .5, .7, 8, 9, and 9. These are myocarditis, myocardial degeneration, cardiomegaly, other ill-defined heart disease, and heart disease unspecified. That's it. So these are the categories and subcategories you're going to code that second code from, and these are sequenced with I-11. And remember, when hypertension and heart disease or failure are diagnosed in the same setting, it is presumed that they are related, and you use I-11, right? Don't code it I-10, code it I-11 from the I-11 category. And only when the doctor documents that they are not related will you code them separately and then sequence the reason for the encounter first. Okay, coders, you with me? Now, when the hypertension damages the blood vessels in the kidneys, reducing their ability to filter waste properly, over time, this leads to CKD, or chronic kidney disease, and you code it as I-12. And we're going to use guideline IC9A2, hypertension and chronic kidney disease, or CKD. And you're going to code it as hypertensive CKD. And this is how you'll code it. Code first, I-12 for hypertensive CKD. Code second, the CKD stage from the N18 category. And remember, coders, when hypertension and CKD are diagnosed in the same setting, it is presumed that they are related, and use I-12 category. And remember, also, if the doctor documents that they are not related, you're going to code them separately. So that means you're going to code the hypertension as I-10, right? And you're going to code your CKD separately. And you will sequence the reason for the encounter first. Okay, coders, how you doing? Does that make sense? Okay, now let's talk about, and when a patient has all three, hypertension, heart failure, and CKD, you're going to have to code all three, and you're going to use guideline IC9A3. And what is that combination code? Well, you're going to code from the I-13 category. You're going to sequence it first. I-13, hypertensive heart and chronic kidney disease. Second, you're going to sequence your stage. Yes, your CKD stage, N18 category. Third, you're going to sequence your heart failure if applicable. And remember, coders, when hypertension and CKD and heart disease is documented as not related, code each separately and sequence the reason for the encounter first. All right. At AMCI, we have a test-taking technique that really will prove helpful if you understand it when you take these medical coding exams. This technique will help you recognize the HTN or the hypertension categories on site. All right. So if you will, all right, so when you have hypertension and no other diseases, 0, right? So think about that 0 and I-10. When you have hypertension with heart disease, think about it this way. You've got one heart, and that one is equal to I-11. When you have hypertension and CKD in the same setting, you've got two kidneys, right? Yeah. So think about that 2 and I-12. And when you have all three, hypertension, heart, and CKD, you got all three conditions, right? So think about that 3 in I-13. So that last character will tell the story. The 0 in I-10 says hypertension and no other diseases. That 1 in I-11, think about that one heart and heart disease and hypertension. That 2 in I-12, you've got two kidneys, hypertension and CKD, and 3, well, that means you've got all three conditions in that I-13. And hopefully, coders, hopefully that resonates. And if it does, you're going to see how much time it will save you. Now, let's go ahead and solve some scenarios. But not before we review how to solve an ICD-10-CM scenario the AMCI way. Number 1, inventory. You're going to inventory all diagnoses, signs, and symptoms. Number 2, select your first listed code. 3, apply guidelines. And 4, trust the guidelines. Trust those guidelines. Remember, this exam is your ability to master those guidelines. So you should trust them. All right, coders, let's get started, and I'm going to hand it over to Miss Dolly.
Hello, coders. I hope you're doing well. Here is your first scenario for today. Of the following, which best describes the encounter? A, I-10, N18.4, B, I-12.9, C, I-10, N18.4, or D, I-12.9, N18.4. A 65-year-old male presents for evaluation of long-standing hypertension. During the visit, laboratory results confirm chronic kidney disease, stage 4. The provider notes that the hypertension has been poorly controlled over the past year, but does not explicitly state whether the chronic kidney disease and hypertension are related. Of the following, which best describes the encounter? Okay, coders, you'll have 60 seconds. Your time starts now. Good luck.
Thank you, Miss Dolly. Okay, coders, how did you do? How was your documentation? How was your inventory? And are you inventorying? Go ahead, type in the chat, let me know. Just to let you know that when you take your exam, you can inventory. And you know what? I inventory because I want to get it right. And that's my easy way to do it. All right, so this patient has long-standing hypertension. The lab results confirm CKD. And just want to let you know this documentation, whenever you're reading these scenarios or looking at these scenarios, these practice questions, this is the provider's documentation. So if you're kind of worrying and saying, oh, well, the doctor didn't document it, yes, he did. All right. The other thing is that the patient, the doctor notes that the patient has poorly controlled hypertension. That's important, right? But also, too, I want you to know that there is no code or even entry in the index for poorly controlled hypertension. There is for diabetes, but not hypertension. But you can look just in case it's changed. All right. I'm just going to get rid of poorly controlled hypertension because it won't impact our coding. But we will need to determine what is the first listed code. And that is going to be hypertension, right? Yeah, hypertension. By virtue of the guidelines, we know that when hypertension and CKD are diagnosed in the same setting, you have to code it as hypertensive CKD. And we just learned a technique, right, to be able to distinguish the codes on site. And if you're looking at these codes, coder, you can eliminate two answers on site. Just saying. All right. Okay, let's go ahead and do our due diligence. Which guideline are we going to reference? Well, I like IC9A2. Yes, this guideline is the guideline for when a patient has hypertension and CKD in the same setting, and it says that you'll need to sequence first I-12 followed by N18, the CKD stage. And on site, we can see which code is sequencing accordingly, right? Okay, so let's get rid of A and C because they're not sequencing from the I12 category, hypertensive CKD. We're going to get rid of them, and now it looks a little better. It looks a little more clear, and you can easily eliminate B, right? Okay, so if we look at I12, this is hypertensive CKD, and this is the code for stage 1 through stage 4, and we have stage 4. Or unspecified CKD, you use I12.9. Now, if you look at the instructional note, it says use additional code to identify the stage of the CKD. On the strength of this note alone, we can eliminate B because B is not coding for the stage. And when you look up the stage, it's N1 8.4, chronic kidney disease, stage 4. So we can eliminate B. And if you said D is the answer, way to go, coders. Way to go. All right, coders. Did that little tip help you in identifying the codes on site? I hope so. Talk to me in the chat and let me know. Okay, Miss Dolly, please and thank you.
Of the following answers, which best describes the encounter? A. I11.0, I50.9, I25.5. B. I11.0. C. I25.5, I50.9, I10. Or D. I25.5, I11.0, I50.9. A 72-year-old patient presents for follow-up of multiple chronic conditions. The provider notes that the patient has hypertension that is well controlled with current medications. The provider also documents heart failure and ischemic cardiomyopathy, which remains stable. The provider specifically states that the patient's hypertension is not contributing to the heart failure or cardiomyopathy, and that these conditions are separate disease processes. Of the following answers, which best describes the encounter? Okay, coders, you'll have 60 seconds. Time starts now. Good luck.
Thank you, Miss Dolly. Okay, we have, this is a little different. Yeah, we do have a patient with multiple chronic conditions. The provider notes that that patient has hypertension, heart failure, and ischemic cardiomyopathy. But that provider also documents that the patient's hypertension isn't contributing to the heart failure and that each of these conditions are separate disease processes. In other words, they are unrelated. So if they are unrelated, can we determine which one is first listed? Well, not without a guideline. And the guideline that I like is guideline C9A1. In fact, many of the guidelines can be used. You can reference many of the hypertension guidelines. And I like this one because this documentation specifies heart involvement, right? With the presumption that you can, when you have hypertension and heart in the same setting, this guidance tells you what to do. Not only does it tell you what to do, it tells you what not to do. All right, so guideline C9A1, if you go to the bottom, it says if it is documented, if these conditions are documented as unrelated, then you're going to sequence as follows. I-10 first, followed by your codes for heart failure, etc. And underneath that, it says sequence according to the admission or the reason for the encounter. We can't really tell why the patient came. It says the patient follows up for multiple chronic illnesses. The provider documents the patient has hypertension, it's well controlled on medications, also documents heart failure, ischemic heart cardiomyopathy. So you can't really tell. So any of them can be sequenced first, right? But what's really important, make sure that you remember you code them separately if the provider documents they're unrelated. And by virtue of sequencing that I-10 first, that's saying they're not related. It's not hypertensive heart, it is just hypertension. So on site, we can eliminate some things because we've learned to recognize these codes on site, right, coders? Yeah, we learned that when there's 1 this is hypertensive heart disease, right? We learned that when it's 0, that means it's just hypertension with no other illnesses. Just saying. And on site, there's only one code, one eligible hypertension code in all of the answers. Just saying. If you had a question like this on your exam, and you could very likely you could have just solved that without even looking up the codes. You just might need to know the guideline though, right? Right. So if you don't know the guideline, you got to look it up, right? Yeah. Why do you look it up? Because these instructional notes do help you too. All right, so let's look up I-11, hypertensive heart disease. We don't have hypertensive heart disease. We just have hypertension, but we do have an instructional note if we did. Also, I-25.5 is this ischemic cardiomyopathy. If you were in the UK, you might say ischemic because that's how they pronounce it, but we say ischemic here. I-10, this is our hypertension with no other conditions, related conditions, and this is essential primary hypertension. And I-50.9, this is our code for heart failure. So on-site coders, we're going to eliminate A because A is coding for hypertensive heart disease, right? We're also going to eliminate B as well, and so too will we eliminate D. And that leaves us with C. And if you said C, coders, way to go. Coders, are you using these techniques? Maybe not now, but we have quite a few more to go. So hopefully you'll trust them and learn to use them. And if you're using them now, that is priceless. And if you're learning something now, that too is priceless. And if you got that correct, outstanding. Okay, Miss Dolly, please and thank you. I think we have a little bit of a technical difficulty, so I will read this. Of the following, which best describes the encounter? A. N1 7.9, I1 2.9, N1 8.3, B. I1 2.9, N1 8.3, N1 7.9, C. I1 2.9, N1 7.9, N1 8.3, and D. I10, N1 8.3, N1 7.9. A 55-year-old female patient is evaluated for worsening kidney function. She has a history of hypertension and CKD, previously diagnosed as stage 3. During this encounter, the provider diagnoses acute renal failure in addition to hypertensive CKD stage 3. Okay, coders, you know what to do. Okay, coders, how did you do? All right, what is your inventory? Did you say worsening kidney function, hypertension, CKD stage 3, acute renal failure? Is this your inventory? If you did something like this, this will help you get to the answer. All right, it was important that I document worsening kidney function because this is the reason the patient was evaluated. And the doctor concluded that this patient had acute renal failure, meaning that acute renal failure is happening right now, right? So that's the condition that is most pressing. But I am going to kind of put a clear underline. I'm going to, not underline, but I'm just going to, yeah, it is underline. Not sort of. I'm going to cross out my worsening kidney function. And the reason is because it's related to a diagnosis on my inventory list. Um, it's related to number 3 and 4. So I'm going to just put a line or strike through it so that I can still see it. Now let's go solve. And I'm just going to tell you off the bat. The reason for the encounter right at this moment is acute renal failure until there is something or some guideline that says otherwise. And the guideline that I'm going to reference is C9A2. This is the guideline for hypertensive CKD because we do have hypertension and CKD in the same setting, but we also have acute renal failure. And in this guideline at the bottom, you'll see that there is some guidance on how to sequence hypertensive CKD with acute renal failure. And it says you're going to sequence first I-12 followed by N1-18, and underneath that, N17, N17.9 can be first, second, or third. And the important thing is sequence according to the circumstances of the admission or encounter or the RFE. Coders, I already said the reason for the encounter is acute renal failure, but it also tells you be sure to read instructional notes in the tabular list just to make sure that you have the most up-to-date guidance. All right, so I'm going to start looking up these codes, and the first code that I'm going to look up is I-12.9. This is the code for hypertensive CKD with stage 1 through 4 CKD or unspecified CKD. This is indeed our case. We do have hypertension with stage 3 CKD. This is a good code. And then I'm reading this instructional note and it says use additional code to identify the stage of CKD. So you're going to code I-12.9 with N18 category, possibly point 0.3. And I'm looking on site, we can eliminate something, right? Just saying, we can eliminate that D. Now let's just go ahead and do our due diligence and look up N18. This is CKD. N18.3 is CKD stage 3. But if you look at these instructional notes, it says code first any associated what? Hypertensive CKD. So hypertensive CKD has to go before N18, period. And again, on site, look at D. D isn't even coding for hypertensive CKD. No, it's coding for degular hypertension. Sorry, I hate to call it that, but it is. All right, so let's continue. Also, this acute renal failure, unspecified, N17.9, to me, this is the first listed code. This is a correct code. And based upon the worsening of the kidney function and the doctor concluding that this patient has acute renal failure, it says that this condition was chiefly addressed, and therefore it is first listed, and A is going to be our answer. But we're going to get rid of B and C because N17.9 has to be first listed. It is the reason for the encounter. And coders, if you said A, outstanding. If you hear sounds in the background, just want to let you know that I have a pup that uses communication tools. So thank you in advance for your understanding. Okay, Miss Dolly, take it away.
Of the following, which best describes the encounter? A. I-10, H35.039, B. H35.039, C. H35.039, I-10, or D. I-10. A 58-year-old female patient presents for an ophthalmology evaluation due to blurred vision. Following a comprehensive eye examination, the ophthalmologist diagnoses background retinopathy and attributes it to the patient's long-standing hypertension. The patient has no other known systemic conditions contributing to the retinopathy. Of the following, which best describes the encounter? Okay, coders, 60 seconds to solve. Your time starts now. Good luck.
Thank you, Miss Dolly. Okay, coders, how did you do? Are you really getting the hang of this? All right, here are my key terms. There was an ophthalmology evaluation. Also, the patient had some blurred vision. That's why they went in to see the ophthalmologist. I know you're saying, why are you emphasizing that? It's going to make sense in a minute. Then the patient was diagnosed with background retinopathy as well as and already had a long-standing history of hypertension, so it was documented in the note. Now, it's time for me to get rid of some things. I'm going to get rid of the blurred vision because it's related to retinopathy. And I'm also going to get rid of ophthalmology evaluation because we're not coding for it. Although they are pertinent, I just want to get rid of them for now. Now, let's go reference the guideline. All right, the guideline that I'm going to reference is C9A5. When a patient has both hypertension and retinopathy, and you're going to sequence it as follow. Look at the third column. You're going to sequence first hypertension. Second, you're going to use a code from the H350 category or subcategory, or you're going to sequence H35.0 first or I10, and you guessed it, the reason for the encounter will dictate how you sequence. And I'm going to eliminate some things on site. I'm going to eliminate B because when a patient has both hypertension and retinopathy, they have hypertensive retinopathy, and the guidelines say use two codes. B is only coding for the retinopathy, and D is only coding for the hypertension, right? But let's take a look at this hypertension guideline first. Underneath hypertension, there is an excludes to note. And if you remember when you were studying, and also too in the earlier lessons, we did talk about excludes to. And that means the patient has to have both hypertension and retinopathy to well, it directs you when they have both conditions to code both, right? So that is your guideline. And also coders, if you don't have the MCG manual, your book is doing some great things guiding you and giving you the instruction. The advantage of having the MCG manual is pretty much knowing those guidelines or having your fingers on the pulse of those guidelines or studying those guidelines before you encounter them on the exam. All right, so this guideline is perfect. This is a good example of excludes two. We have both conditions, so we're going to code them both. And D got to go because it's only coding for one. And also, if you didn't know, retinopathy, background retinopathy is the first listed code because why? Because it was chiefly treated, right? We have an ophthalmology evaluation. We have an ophthalmologist carrying out that ophthalmology evaluation. So the reason for the encounter that that patient came in that door, the reason for the encounter is the retinopathy. Ophthalmologists don't specialize in hypertension. They're not treating the hypertension. They're treating the retinopathy, the hypertensive retinopathy. All right, so we are directed to use code H35.039, hypertensive retinopathy, unspecified I. And we're going to sequence it first. So that will eliminate A, and C is our answer. And if you said C, outstanding. But if you learned something, that's priceless. You could have learned how to, basically deduce what the first listed code should be. Hopefully you did. And also, I want to point out that this is an example of how the circulatory system. And if it malfunctions, it could impact your eyes. Just saying. All right. Take it away, Miss Dolly.
Based on ICD-10-CM guidelines, how should this encounter be coded? A. I15.1 E27.5. B. D35.00 I15.2. C. I15.2 D35.00. Or D. D35.00. A 45-year-old female patient presents with persistent elevated blood pressure, headaches, and sweating. Laboratory tests and imaging confirm the presence of a benign pheochromocytoma, which is determined to be the underlying cause of her secondary hypertension. Based on ICD-10-CM guidelines, how should this encounter be coded? Okay, coders, 60 seconds. Your time starts now. Good luck.
Thank you, Miss Dolly. Okay, coders, is your inventory persistent elevated blood pressure, headaches, sweating, pheochromocytoma, benign, underlying hypertension? So it's secondary hypertension. Are these your key terms? Well, if they are, good. Now let's go ahead and eliminate some signs and symptoms that are integral to a disease, illness, or injury on our inventory list. Well, kind of got ahead of me, but headaches. Yeah, we'll start with that. It is related to 4 or 5, right? Yeah. Also, elevated blood pressure. We know that it's related to underlying hypertension or secondary hypertension. And so too is sweating. Now, this pheochromocytoma, and it's benign, it's a rare tumor. It's usually not cancerous, but it is a tumor in the adrenal gland. So maybe these three are related to pheochromocytoma, but we know they're related to hypertension. Okay, coders. Oh, also too, secondary hypertension is a hypertension that is caused by something else. So this benign pheochromocytoma is the cause of the secondary hypertension, and the documentation even says so. Now, let's go see if there's a guideline that helps us sequence or select the first listed code. Now, if you reference guideline C9A6, this is the guideline for secondary hypertension. And if you look at the third column, it says when you have secondary hypertension, the code is I15. And you sequence either that first and the underlying condition, or the underlying condition and the secondary hypertension can be sequenced second. So it largely depends on the reason for the encounter. All right. So you are going to need two codes. Just saying. So if you need two codes, let's go ahead and get rid of D. It's only coding for that tumor. Now, let's go ahead and look up our codes. If you look at I-15.1, this is hypertension secondary to other renal diseases, kidney diseases. But that's not our circumstance. Pheochromocytoma is a benign tumor of the adrenal glands. They sit right behind the kidneys, right? And but they are not kidneys. They are part of the endocrine system. Yeah, so your adrenal glands are a part of the endocrine system, and I-15.2 would be your correct code. So on that note, we know we can get rid of A. But let's go ahead and just do our due diligence. D35.0, benign neoplasms of the adrenal gland, at least that's specific. And D35.00 is the code for unspecified adrenal gland. That is correct. The documentation does not specify right or left, laterality. All right, so since it doesn't, let's just go ahead and get rid of A. And basically, we're going to have to make the determination based on the reason for the encounter. So the reason for the encounter, the reason that patient came through the door is that benign pheochromocytoma. It is the reason the patient came, and it is the cause of the secondary hypertension. So pretty much the secondary hypertension is a manifestation of that. And in general guidelines direct you to code manifestation second, unless they unless the treatment is directed at that manifestation. Just saying, I wish I had the guideline to reference. If you know that guideline, coders, it's a general coding guideline about manifestations. Make sure you go reference it. And if you know where it is now, go ahead and put it in the chat. All right, so since the benign pheochromocytoma is first listed, we are going to get rid of C, and B is our answer. And if you said B, outstanding. But if you learned something, go ahead and say aha and pat yourself on the back at the same time, because that is priceless. Okay, Miss Dolly, please and thank you. I found it. I found the guideline. The guideline is A13. So it's not necessarily a general coding guideline. It's a convention, guideline A. Anytime you have an etiology or manifestation circumstance, then you're going to code the etiology first. You're going to sequence the manifestation second. The etiology pretty much means due to. When a condition is due to, that due to will get sequenced first. And in this case, the pheochromocytoma was the condition that caused the secondary hypertension. In other words, secondary hypertension was due to the pheochromocytoma. So pheochromocytoma is the etiology, it is the source, and you code it first, followed by secondary hypertension. Okay, Coder, so this is a prime example of why having recorded sessions are advantageous, right? I was able to go grab that guideline and show you. Aha, teachable moment for some people, hopefully. Okay, coders, I digress, but I'm back to the next scenario. I'll read this one. Of the following answers, which best describes the encounter? A, I13.10, I50.22, N18.30. B, I10, I50.22, N18.30. C, I13.11, N18.30. I50.22, D, I13.0, N18.30, I50.22. A 74-year-old male patient with a history of hypertension presents with increased shortness of breath on exertion, new 2 plus pitting edema in both lower extremities, and weight gain of 5 pounds over the past week. The provider documents chronic systolic heart failure and stage 3 CKD. Medication adjustments were made, including increasing the dose of furosemide and initiating lisinopril. The patient was referred to nephrology for continued CKD monitoring. Okay, coders, you've got 60 seconds. Your time begins now. All right, coders, how are you doing? What was your inventory? Did you say hypertension, shortness of breath, new 2 plus pitting edema, lower extremities, weight gain, and chronic systolic heart failure, CKD stage 3? If you said that, very good. And if you said something else, type it in the chat. Go ahead. All right, now I'm going to get rid of signs and or symptoms of a disease, illness, or injury on this list to kind of make things, so I can highlight those that I need to code for, because too much is too much for me. So I'm going to get rid of shortness of breath because it's integral to hypertension, especially heart failure, especially. I'm also going to get rid of pitting edema. And if you don't know what that is, I'm going to show you in a moment. And I'm also going to get rid of weight gain. These are all related to CKD and heart failure, mainly heart failure, if you ask me, but they're related to at least one disease or diagnosis on this list. And if you want to know what pitting edema is, that's when the doctor, puts his fingers on the location where the swelling is or the edema is, and if it remains there for a specific length of time, then that is pitting edema. And then they do stage them. This may be plus 2 plus or 3 plus. I'm not sure, but I'm no clinician. But this is what pitting edema is, and this is our inventory or keywords. Now, which guideline are we going to reference? And the guideline that we used is C9A3. And this is the guideline when a patient has all three conditions. They have hypertension, heart failure or heart disease, and CKD, all three. And the guideline is 3 too. Just saying, not to get off task. All right, so if we look in this third column, it says that when you have all three, hypertension, heart, and kidney disease, you'll sequence first your hypertensive heart and CKD code, followed by your CKD, and third, your heart failure. All right, coders. On site, we can eliminate something, right? Okay. We can eliminate B because it's only coding for the general hypertension code, using that general hypertension code. And yeah, we're going to, hypertensive CKD will be our first listed code because that's all that's left in the answer selection, and the guidelines say it as well. Now, this is the code for essential hypertension. Our attention now is on A, C, and D, and the difference between the code is the fourth character. So I13.0, I13.10, I13.11. If we look at I1310A, this code says this is hypertensive heart and CKD without heart failure. Yes, that's the key word. We do have heart failure. We have chronic systolic heart failure. So we know that's incorrect. And so too is I13.11, because this is also hypertensive heart and CKD without heart failure. And these are without heart failure, and the difference between these two codes, just so you know, 10 is coding for stage 1 through stage 4, and 11 is coding stage 5 and stage 6, or end stage. So that's the difference in these codes. But both are incorrect because they're not coding for heart failure. So we can go ahead and get rid of them, right? And that leaves us with D. But let's continue and let's do our due diligence, and let's look up that systolic heart failure code, I50.22. This is the code for chronic systolic or congestive heart failure. There you go. That is our code. And D is correct. It's coding for the hypertensive heart and CKD with heart failure stage 1 through stage 4. You know, we've got stage 3, right? And then the next code, our stage, our CKD stage 3 code. I don't need to look that up, do I? Because we've seen it a couple of times. And then I50.22, this is your systolic heart failure code, and it's sequencing appropriately. So, coders, if you said D, outstanding. Yeah, I put it up there for you. If you said D, outstanding. If you learned something, coders, if you did, that is priceless. Go ahead and let me know if you did. Just say aha in the chat. All right. But I think you all are getting it, right? All right, we have one more scenario on the subject of hypertension. Let's do it.
Of the following, which best describes the encounter? A. I16.0, B. I10, I16.1, C. I16.1, I10, D. I16.1. A 63-year-old male patient presents to the emergency department with symptoms of severe headache, chest pain, and significantly elevated blood pressure readings. The provider diagnoses a hypertensive emergency due to the presence of acute end organ damage involving the kidneys. No previous history of hypertensive crisis is documented. Of the following, which best describes the encounter? Okay, coders, 60 seconds to solve. Your time begins now. Good luck.
Okay, coders, how are you doing? You doing good? I know I'm moving a little fast for some, and fast for my liking too, but we've got a lot of work to do, and you may always go back, listen, and rewind. If I'm speaking too fast, you can slow it down. If I'm speaking too slow, you can speed it up. Always on your controls in YouTube. All right, so my keywords are this patient presents to the ED. Just want to make that clear. That means there is some type of emergency. Patient's got a headache, chest pain, elevated blood pressure readings. Then the provider diagnoses the patient as having a hypertensive emergency due to the presence of acute and organ damage involving the kidneys, and there's no previous history. All right, so my keywords are severe headache, chest pain, elevated blood pressure, hypertensive emergency, acute kidney damage. Yes, and just so you know, acute end organ damage refers to the kidneys being all of a sudden severely impaired. All right. So it's not end stage renal failure or anything like that. And remember, end stage renal failure is not acute, it's a chronic condition. Now let's go ahead and get rid of these signs and symptoms of a disease or illness or injury on our list, mainly our diagnosis. All right, so we got rid of these, and that leaves us with hypertensive emergency, acute kidney damage. I like guideline C9A10, right? This is the guideline for hypertensive crisis. So it could either be one or two circumstances. Your crisis could be either an emergency, hypertensive emergency, or a hypertensive urgency. Now, the emergency is most complex. Both have elevated blood pressures, like blood pressures at very high numbers, but the emergency also involves organ dysfunction. Take a look at our inventory at the top. We have some organ dysfunction, right? Yes. So I believe this is an emergency based upon this guideline, and it tells you need to sequence first I-16 if it is the reason for the encounter, followed by your hypertension code, or your hypertension code followed by your crisis code. And somebody might say, well, wouldn't a crisis always be the reason for the encounter? Maybe not. A patient could be at the doctor's office perfectly normal for a totally, maybe just checking on their hypertension. Then all of a sudden they go into this crisis. You still have to code for the reason for the encounter, especially if it was chiefly treated. But yes, you are correct. Often that emergency will be most chiefly treated. So hopefully that will answer a question that somebody might have. Now let's go ahead and let's choose our code. And I think we can eliminate some things on site. Based upon the sequencing guidance, we need two codes. We always need two codes when you're having a hypertensive emergency or crisis, right? So A and D are only coding for that crisis and not the hypertension. So we can eliminate both A and D. And that leaves us with B and C. And yes, we can deduce that this patient came into the ED and the patient is having this emergency. So we should select C, correct? Yeah, but we don't have to use our deductive reasoning. We can just look at the guidelines. All right. So I-16 category tells you to code also your hypertension. But when you have an emergency, like I said previously, it involves organ dysfunction. And if an organ dysfunction is documented, you will need to code it. And we do have a documented acute kidney injury or damage, right? Yeah. And C is actually coding for that acute kidney damage. I'm going to let that marinate. And why I'm letting that marinate is just know that the difference between urgency and emergency is the organ dysfunction. Okay, coders. So that means that B is incorrect, right? So let's go ahead and look up our code. I-10 is for primary hypertension. You can sequence it when the primary hypertension is your chiefly treated disease, but it's not. We're in here for that hypertensive emergency, and C is our answer. And coders, if you said C, outstanding. All right, coders, how do you feel? Ready to shift gears? I hope so, because now we're going to talk about strokes.
And what is a stroke? Well, we said earlier that a stroke happens when blood flow to part of the brain suddenly stops. In other words, those pipes, those arteries, they're clogged and the brain cells in that area begins to die because they aren't getting the oxygen and nutrients that they need. So circulation is stopped, paused, or compromised. And there are two main types of strokes. The two main types of strokes are on the right, your ischemic stroke, and this is caused by blocked blood flow to the brain, and it's usually from a clot or a thrombus, as you can see below. And a hemorrhagic stroke, this is caused by bleeding on the brain due to a ruptured blood vessel. And these are less common, and they're more deadly, of course, but both can lead to death of brain tissue. So let's just take a quick look at how to code them. A hemorrhagic stroke has two classifications. You have I-60 subarachnoid category. In other words, the stroke is actually occurring within the meninges or the meninges. And there are three layers to those meninges. You have your pia matter, your dura matter, and your subarachnoid or your subarachnoid matter. So the dura is it's the outermost layer, and this actually protects the brain. So when the stroke is within the meninges, that you will use I-60 subarachnoid subcategory. Another location of a stroke is intracerebral or beyond the meninges, right? So anytime the stroke is further along beyond the meninges, then it's intracerebral category that you'll use. And if you look at this picture, you can see the hematoma just underneath. Let me see. Hopefully you can see I don't know if you can, but where hematoma is written, you can see the stroke is pretty much, I can't really tell. I can't tell if it's subarachnoid or intracerebral because it looks like it's sitting right at the meninges. So if I were to guess, it's I-61 category. Now, ischemic stroke, again, this is about 87% of the strokes. And you'll code from I63 category. So your documentation will specify the type of stroke. But both can cause brain death, and that can lead to residual effects. Yes, sequelas, right? So you can experience left-sided weakness, hemiplegia, monoplegia, and more. Now we're going to learn how to code for these residual effects. But first, let's review the guideline. Guideline IC-9C. This guideline is when an intraoperative stroke occurs, basically while the provider is carrying out a procedure. The patient has a stroke, and an intraoperative stroke occurs when the patient is under anesthesia for another procedure. It can be either ischemic or hemorrhagic, but most are ischemic because ischemic strokes can occur when hypotension takes place. The doctor either lowers the blood pressure or systemically the patient's blood pressure lowers. Also, embolisms like clots or air bubbles, that can cause a stroke intraoperatively. And sometimes for certain procedures, they have to clamp the carotid artery. Clamping or manipulating it in some way can cause a stroke. Yeah, or a patient could experience AFib or arrhythmia or any type of inadequate anticoagulation anytime when they're trying to increase clotting. That could cause a stroke. Now, how do you code it when it's intraoperatively? Well, you're going to follow the guidelines in the third column. You're going to code first from the I97 subcategory. You're going to sequence second your type of stroke, I60 through I67 if the type is documented as ischemic or hemorrhagic. And remember, there are two basic types of strokes, and they're also known as CVA, cerebrovascular accidents. And the documentation must clearly state the cause and effect relationship. The doctor has to say that this is an intraoperative CVA and the type of stroke, and the doctor has to say why. They have to specify. Now, I do want to tell you, for those of you that are studying for your CCS, this is not a hack. No, this is not a hospital-acquired condition. Well, how do you know, Mrs. J? Because I looked it up. I did. I looked up the I97 category, and there are no hack indicators. And you see at the bottom, hacks H1 through H14 are not documented. And there's no classification for that type of hack. None. All right, so I digress. I apologize, coders, for the majority of you, but I had to take advantage of this teachable moment for my CCS students. All right, let's continue. Let's study guideline IC9D1. This is the guideline for sequelae of cerebrovascular accidents or strokes. So we've learned that sequelae are the residual effect, and these strokes often cause conditions or residual conditions that pertain to laterality, or the side of the body affected. And we will have to consider dominancy. Dominancy meaning the side that the patient writes with. So their dominant side when coding the sequelae, all right? So very similar to pain codes. you'll need to consider the following when coding for sequelae of a stroke or the residual effects. Now, you'll code first your residual effects code. And remember, you're not coding for the stroke. The stroke has taken place. The stroke is no longer acute. And you are now coding for the residual effects, what happened after the stroke. That is what the treatment is directed at. And you'll need to remember that dominancy will be dictated by the writing hand of the patient. Now, when the documentation does not specify dominancy, then you will default to the following. Very similar to what you already know about pain and nervous system, the right-sided injury will be dominant. So you will proceed as if the patient is right-handed. So the right injury will be dominant. The left injury will be non-dominant. And if the patient is ambidextrous, well, it's not documented, but if the patient should be ambidextrous, the injured side will be dominant. And remember, if residual effects occur simultaneously with the stroke, then you'll need to sequence the reason for the encounter. However, this is rare. It's rare to see a patient being treated for the residual effects while a stroke is happening. But it can happen, coders. Now, I just want to make you aware of some common residual effects of a stroke: hemiplegia, dysphagia or aphasia. Dysphagia means difficulty speaking. Aphasia means they can't speak. Dysphagia means they have difficulty swallowing. And I tell the difference. People confuse those two, but think about the GI tract in dysphagia. They have a GI near the end. Think about that's your gastrointestinal system, right? Swallowing. There you go. So that means it can't swallow, and that's a part of your digestive system. All right. There are cognitive defects like memory loss, ataxia or gait disturbance, visual defects, and mood and behavioral changes. Yes, these strokes can cause these conditions, and these are considered residual effects or sequelae. Now we got one practice question for you, and don't forget how to solve an ICD-10-CM scenario the AMCI way. Number 1, inventory. Number 2, select your first listed code. 3, apply guidelines and trust the guidelines. Okay.
Of the following answers, which best describes the encounter? A. I63.9, I10, B. I63.9, C. I10, I63.9, and D. I67.4. A 70-year-old male is admitted to the hospital with slurred speech, facial drooping, and right-sided weakness. Imaging studies confirm an acute ischemic stroke. The provider's documentation notes that the stroke is the result of the patient's uncontrolled hypertension. Okay, coders, what say you? Your time begins now. my inventory. Okay, coders, what do you have? Do you have slurred speech, facial drooping, right-sided weakness, acute ischemic stroke, and uncontrolled hypertension? And it says the stroke is the result of the patient's uncontrolled hypertension. All right, coders, what do you do? Are we going to code for these clinical indicators? Are we going to code? Did you notice that these indicators are also the sequelae? They're the late effects. Well, we don't know, right? We have to reference the guideline, and I'm going to get rid of them. The reason I'm going to get rid of them for now is because it appears that these are indicators of a diagnosis on my inventory list, right? So all of these are indicators of a stroke, an ischemic stroke. So I'm going to just kind of strike through them momentarily. Is that okay? All right, coders, let's solve. The guideline I would reference is IC9D1. This is the guidance for sequelae of cerebrovascular disease. So it's going to tell me if I'm going to code this stroke, right? Am I going to code this sequela? Well, the reason I am because I want to know if I need to code the sequela. And essentially, if the encounter is for that slurred speech, facial drooping, and right-sided weakness, I would code from the I69 category. And it also says that this is rare for coding a current stroke. It's rare. You don't code these sequela when the acute stroke is happening. So I just wanted to show you that. I got another guideline for you too. I would use guideline IC9A4. I went back to the hypertension section and I found this guideline for hypertensive cerebrovascular disease. And when you have hypertensive cerebrovascular disease, you have to sequence first I60 through I69 codes, second your hypertension codes. But there is some guidance when you can use this code. Below the sequencing, it says the provider must document the relationship between hypertension and cerebrovascular disease. So you just can't use these codes if hypertension and stroke are in the same encounter, documented in the same encounter. The doctor has to link them. All right, so our doctor says the stroke is a result of the patient's uncontrolled hypertension, so therefore we can use this guidance. All right, we need two codes, one from I60 through I69 and one HTN code. On site, we can eliminate two because both B and D are not coding for the hypertension. And now we're left with A and C, and we're going to have to sequence the I60 through I69 category first because that is your acute stroke. It is happening right now, and therefore it is the reason for the encounter. So I63.9 is cerebral infarction, unspecified. I like these tips. Coders, read these tips when you can. It says, tip, when provider documentation does not identify the location of an infarction, imaging reports can be used to pinpoint the location and lead to a more specific infarction code. So if it was documented up in here, the location based on the imaging reports, you can code it. Just saying. Also, I10, that's your essential or primary hypertension code. And again, we're going to sequence our stroke first, and C will be eliminated. And coders, if you said A, outstanding. But if you had an aha moment, let me know. I want to know. All right, it's time to switch gears. And now we're going to talk about myocardial infarctions or heart attacks.
What is a heart attack? Or we refer to heart attacks as an acute myocardial infarction. And that's pretty much when blood flow to a part of the heart gets blocked. The pipe is clogged. And usually this can happen by a blood clot, and this keeps oxygen from reaching the heart muscle. And if that blood does not reach the heart, that tissue can become damaged or die. Remember, this is our most vital organ, or one of them, right? We've got two. All right, so this still involves circulation. Now, let's talk about some components or some necessary things that you need to code for heart attacks. When coding for these acute myocardial infarctions, you'll often have to code for the location of the infarction. So they typically are predicated on the arteries, the major coronary arteries and or their branches. So when the infarction occurs around those arteries, they identify the location. So you don't have to remember all of the arteries, no, but just so you know, when you get to we call it part 3, but when you get to advanced CPT, you're going to learn about these arteries. There are 5 major arteries. You've got your left main, your left anterior descending, your left circumstance, right coronary, and ramus intermedius. But you will, when you're coding these, you will be given information in your documentation. It'll specify the location, and this will help you determine the most specific code. All right, so I just thought I would tell you, and some of this may look familiar when you're solving some scenarios. Also, these infarctions have types. All right, from the perspective of the MCG manual, we've classified these types. Yes, you have types 1, 2, 3, 4, and 5, and type 1 is your most common type of myocardial infarction. So these are acute, happening now, spontaneous, and the code series will be at the bottom, I21.0 through I21.2. Now, when the documentation doesn't specify the location of the infarction, I21.3, and I should say that when the documentation doesn't specify the type and the location of the infarction, I21.9. I think I'm going to put that in the MCG. All right, and your non-STEMI is I21.4. So the STEMI is the acronym for ST elevation myocardial infarction. Non-STEMI is non-ST elevation myocardial infarction. All right. Now, type 2, these are due to demand ischemia, and pretty much the underlying cause may be sequenced first, followed by your I21.A1. Type 3, these are myocardial infarctions associated with revascularization procedures. So if someone is, having when they're rewiring the heart, I21.A9. Type 4 is myocardial infarctions related to percutaneous coronary interventions. So when you get to part 3, you're going to learn how to code them. And these are procedures like stents, angioplasties, balloon angioplasties, etc. So if an infarction occurs while that is taking place, it is a type 4 I21.A9 and type 5. These types are related to cabbage, and these are procedures, kind of rewiring procedures, but not in the same context as a type 3. You'll learn about them when you get to the CPT portion, but cabbage is coronary artery bypass grafting. So when that is taking place, I21.A9, and it's classified as a type 5 infarction. So this little chart is in your MCG manual. So if you want to take a peek, go right ahead. It's table 28. Now, let's go ahead and talk about coding for these acute myocardial infarctions. All right, the first guideline is IC9E1. This is the guideline for a type 1 acute myocardial infarction. So it's pretty much, we learned that it's going to either be a STEMI or a non-STEMI, right? So if it's a STEMI, then you use I21.0 to I21.2 or that I21.3. Now remember, when the patient is diagnosed with both a STEMI and a non-STEMI, let's say they had a non-STEMI and it evolves to a STEMI, you're only going to code STEMI. All right? And also remember that STEMI and non-STEMI are type 1 infarctions. And finally, make sure you read forensically to determine the code. Yes, these codes can be specific, and they are pertinent to the coronary arteries or that location of the coronary artery. But trust, they will tell you the location, and it is documented in the code descriptive. All right, let's go. We got another guideline, and this guideline is when the acute myocardial infarction is older than 4 weeks. Let's say they had an infarction like a year ago. Then it would be considered an old myocardial infarction, and you will use guideline IC9A1. And these are just type 1 older infarction. So if it's a type 1 infarction that's older than 4 weeks, then you will code I25.2. However, if they are still receiving care, you'll need to sequence that aftercare code first. All right? And if they're not receiving care for the infarction, then you will code the I25.2. Now, if they're having a current infarction right now, and let's say they have a documented older infarction. If that older infarction is less than 4 weeks, there's a certain way you're going to code it, right? But if it's older than 4 weeks, you're going to code I25.2 secondary. And remember, coders, old myocardial infarctions are older than 28 weeks, greater than 28 weeks.
Coders, did you know one of the most common risk indicators or clinical indicators for a future acute myocardial infarction or heart attack is a prior heart attack? Yes. And when a patient has had a subsequent heart attack, that means they had a heart attack before and they're here today for another heart attack. Guideline IC9A4. And when a person has had a type 1 subsequent heart attack, you're going to follow these guidelines. Number 1, you're going to use 2 codes, I22 and I21. Now, the sequencing will depend on the reason for the encounter. Almost very often, I22 will be sequenced first because that is the code for your subsequent infarction, and I21 will be sequenced second because that is the code for your acute infarction, that first one. All right, so it boils down to the documentation, but very often I22 is sequenced first. And remember, if if they're there for a subsequent infarction, that first infarction must have been 4 weeks ago. Within that 4 week period, if it's beyond that, then it's coded differently. And that brings us to number 3. Remember, if the subsequent infarction occurs after 4 weeks, then you are going to use category code I25, specifically code I25.2 for old myocardial infarction. And finally, pay attention when you're coding for these infarctions. Pay attention to the type. Is it type 1 through type 5? And the location on the heart of the infarction, specifically around those coronary vessels, those major coronary vessels and their branches. Okay, I got something for you. In the MCG manual, and this is 2025, table 29, it's just after the section that we're referencing. We have a chart on how to code type 1 acute myocardial infarctions. So pretty much, if the patient's admitted for an acute infarction, you have to ask yourself, did they have a previous infarction? If the answer is no, follow the guidelines or the guidance in this first column. If they did have a previous infarction, follow the guidelines in this second column. All right. So you'll need to determine if that previous infarction was 28 days. If it's not older than 28 days, then you're going to sequence it like this. I22 followed by I21. Now, if it's older than 28 days, beyond that 4 weeks, I21 category followed by I25.2, that old myocardial infarction code. Now, down here, this pertains to if the reason for the encounter is something other than a heart attack. All right, so we're not going to review that. We're just going to keep our attention up here just so we can stay focused. Now, coders, I've given you some tools. So I want you to take a moment to process, and then we're getting ready to code. Yeah, you can do it. You can and you will. Okay, coders. First, inventory, right? We're going to inventory all diagnoses, signs, and symptoms. Next, we're going to select that first listed code. When we can, we do it. And third, we apply the guidelines. Okay, coders, you can do this. Of the following answers, which best describes the encounter? A. I21.4, B. I21.3, C. I21.11, or D. I21.02. A 65-year-old male presents to the ED with acute chest pain and shortness of breath. An ECG and cardiac enzymes confirm a type 1 ST elevation myocardial infarction involving the left anterolateral wall of the heart. Okay, coders, your time begins now. All right, coders, what are your key terms? What did you inventory? Did you inventory acute chest pain, shortness of breath? Then, after study, the physician diagnosed the patient with a type 1 STEMI of the left anterolateral wall, right? So this is where the infarction took place. Likely, this is the tissue that was either destroyed or damaged, right? This left anterolateral wall. Now, let's go ahead and let's get rid of some things that are integral to this STEMI. So we can say that an acute chest pain is integral to that STEMI, that heart attack, and shortness of breath. Both are clinical indicators. Now, let's go ahead and solve. And our job is to choose the code that's a type 1 STEMI of the left anterolateral wall. So which guideline am I going to use? I'm going to use guideline IC9E1. And this guideline basically says if you're coding for a type 1 STEMI, you're going to code from I21.0 to I21.2. And this is where you're going to code from. And pretty much I think we are within that. Yeah. Except this I21.3, I did point out that this is a non-specific type 1 STEMI. Hey, coders, maybe you should document that next to this note in your MCG manual. And I'm going to document it for you. So in 4 weeks, you will see it. But this is the non-specific code. So if it's non-specific, and we know that our location of our infarction was specified, we will not be coding I21.3, just saying. Also, down below as well, it says for an NSTEMI, it's I21.4. Coders, I see I21.4 at A on site. We can eliminate A and B. And our attention really just needs to be on C and D. But we're going to do our due diligence. Yes, we're going to get rid of I21.4. This is the code for non-ST elevation NSTEMI. Not going to happen. We had a type 1 STEMI. Now, I21.3. This is the code that I said was not specific. So this is a STEMI of an unspecified site. The location of the STEMI is not mentioned if you use this code. But you know what? We know our location of our STEMI. It's the left anterolateral wall. That is what we're looking for. So let's go ahead and get rid of I21.3. Now, if we look at I21.1, this is the code for ST elevation STEMI myocardial infarction of inferior wall. Not a whole lot of information, but I like to keep reading. This is what I was telling you, that if you read, then you'll actually be able to determine the answer. So this code is for ST elevation myocardial infarction of inferior wall. We're looking for anterolateral wall. Anterolateral is not the same as inferior. So I'm going to look down, and this is actually our code I21.11, and this is ST myocardial infarction involving the right coronary artery. You know what? I'm not sure if this is the right coronary artery, but the right coronary artery the branches are anterolateral, but underneath it says inferoposterior. So this is the posterior wall. This is the back of the heart. And I am aware that the right coronary vessels do go behind the wall, behind the heart. So more than likely this is not our code. Now let's see what I2102 says. And we're going to get rid of this I21.3, right? Yeah. So I2102. ST elevation STEMI of anterior wall. Yes, anterolateral means anterior lateral. I like we're going in the right direction. And if we look at I21.02, this is the ST elevation involving the left anterior descending. Okay, left anterior descending is a coronary vessel, a major coronary vessel. However, we're coding for somewhere around that branch. And if you look, it says ST elevation, myocardial infarction involving diagonal coronary artery. All right, so there's not enough information to really help us, but this information, I210, this is the code for anterior wall type 1 ST elevation myocardial infarction of anterior wall. That's all we have. Now it is our job to pick the best of the four. And you know what, coders? While I don't like the fact that it's not specific enough, I2102 is coding for the anterior wall. That is our key word. And I am going to select D. I'm eliminating C because it's coding for the inferior wall. And if you said D, that's because you were doing some forensic reading. Indeed, you are. And I just got to tell you, outstanding. So, the moral of this story is that you have to pay attention to the key words. Indeed. All right. I got one more for you. Then I'm going to hand it over to Miss Bianca. Of the following answers, which best describes the encounter? A. I22.09, I21.3, B. I21.9, I22.09, C. I22.1, I21.09, and D. I22.09. A 65-year-old male patient presents with chest pain and is admitted for evaluation. Diagnostic testing confirms a second ST elevation myocardial infarction, STEMI, occurring within 3 weeks of the patient's initial STEMI. The documentation specifies that the second infarction involves the inferior wall, while the initial infarction affected the anterior wall. Of the following answers, which one describes the encounter? Okay, coders, your time begins now. I know it's a lot, coders. I know it is, but we are doing the work and you are doing an amazing job. And tell yourself that. Pat yourself on the back. All right, here is the inventory list. We have chest pain, admitted for evaluation, diagnostic testing confirmed, a second STEMI. So that's a type 1 of the inferior wall. So that means even though it's a subsequent infarction, they're in that hospital for that subsequent infarction. They're in there today for the subsequent infarction because the previous infarction occurred 3 weeks ago. So pay attention to the location of the infarction today as well as the infarction 3 weeks ago. Also, so that we can only focus on what we need to focus, let's go ahead and get rid of those items that are integral to a diagnosis on this inventory list. All right, so if we say chest pain, we can let that go because it is related to the STEMI. Admitted for evaluation, we're not coding for an admission. We're not coding for any evaluation and management, only the diagnoses, right? So we're going to get rid of that. And we're not going to code for diagnostic testing, but it's important. So we have a strike through. Now let's go. Before we code, I just want to show you some visuals. Maybe this will help. All right, so earlier I showed you how to code a type 1 infarction. I also showed you, your list, your a graph or an image of the different types. So we are coding for a type 1 STEMI, but we're also coding for a subsequent STEMI, right? So if we use the chart below and answer the questions, the patient is admitted for an acute type 1. So we can say, yes, it is a type 1 because it's a STEMI, right? Also, we need to answer the question, did they have a previous infarction? Did they have a previous one? And if you say no, then you just code here, find this guidance. But if they did, you go over here and you go to the next question. If not older than 28 days, which is 4 weeks, then this is what you do. And it is our situation, our infarction occurred 3 weeks ago. So because it's within the 28 days, we are going to do the following. Our first code is going to come from I22 category, and then the second code will come from I21. And that's pretty much it. And I do want you to pay attention to the location of your infarctions, and you're good to go. Now, I'm going to reference guideline IC9E4. IC9E4 tells you when you have a subsequent type 1 STEMI and you had it within 4 weeks of another one, I22 followed by I21. On site, we can get rid of something, right? Look at B. It's coding I21 first, followed by I22. Now let's go ahead and look up our codes. We have I22.9. This is a subsequent STEMI of an unspecified site. Well, if you look above, here's our subsequent STEMI, but the site is specified as the inferior wall. So this I22.9, you got to go. Just saying. Just saying. All right, so let's look up our other codes. We have I22.0. This is ST elevation STEMI, myocardial infarction of the anterior wall. I don't think this is right because the subsequent STEMI is of the inferior wall. And our I22 code has to say inferior. In I22.1, here you go. Subsequent ST-STEMI myocardial infarction of the inferior wall. And I only see one correct answer. Just saying. All right, let's keep looking. All right, so if we look at I21.9 and you find that at C, I21.9 is acute myocardial infarction unspecified. Well, our myocardial infarction is specified. It's specified as a type 1 and it's specified as the anterior wall. So we're talking about that acute myocardial infarction 3 weeks ago. So this is not a good code either. So let's continue by doing our due diligence. I21.09, this is the code for ST, elevation myocardial infarction involving other coronary artery of anterior wall. I like it. All right, so this is the first infarction that occurred 3 weeks ago. You still code it as current, but it's sequenced second. So the answer is D, subsequent ST elevation or STEMI of the inferior wall, and ST or STEMI infarction of other coronary artery of anterior wall. These are the best of the four answers, and I'm going with D. Okay, coders, how do you feel? You feel good? And you should. You are doing amazing. Okay, so I am ready to hand you over to Miss Bianca. She's going to close things out with a couple more scenarios. Okay, Miss Bianca, please and thank you.
Thank you, Ms. J. Okay, coders, based on the ICD-10-CM guidelines, how should this encounter be coded? A, I21.01, B, I21.21, C, I21.4, D, I21.3. A 58-year-old male presents with chest pain and shortness of breath. Laboratory tests and ECG confirm a subendocardial myocardial infarction involving the anterior septal wall. Based on ICD-10-CM guidelines, how should this encounter be coded? You have 1 minute to solve. All right, and let's take a look at our AMI chart from the MCG manual. And in here we have a type 1 STEMI or NSTEMI acute spontaneous myocardial infarction related to some of these more spontaneous events here. And since we have a subendocardial myocardial infarction and there's no mention of ST elevation, we're going to go with an NSTEMI. And as you can see right here, it gives you NSTEMI I21.4 down here. But let's go ahead and look at our inventory list. And I have chest pain, shortness of breath, and subendocardial MI involving the anterior septal wall. I'm going to get rid of 1 and 2 just to shorten it down for us. And so the subendocardial MI involving the anterior septal wall is the only thing we're going to be coding for. And the guideline I used was Chapter 9E3. And this guideline also tells us that when we have an AMI documented as non-transmural or subendocardial with site provided, we code first the I-21.4, which is similar to the chart that we just looked at. And let's take a look at the code even though we know the answer. And this tells us it's a NSTEMI myocardial infarction. And down here you can see we have the acute subendocardial myocardial infarction listed. So this is definitely our code. So C I-21.4 is our answer. Based on the ICD-10-CM guidelines, how should this encounter be coded? A, I-21.9, B, I-21.3, C, I-21.A1, D, I-21.A9. A 72-year-old female patient is admitted to the hospital with symptoms of chest pain and shortness of breath. The provider documents acute myocardial infarction, but does not specify the type, site, or additional details regarding the infarction. You have 60 seconds to solve, and your time begins now. All right, and let's start with our inventory list. I have chest pain, shortness of breath, acute myocardial infarction, and site not specified. I'm going to eliminate the chest pain and shortness of breath to make our list a little bit easier. And the guideline that I used to help me solve this one was Chapter 9E2. And this tells us an unspecified AMI, if type and site are not documented, you code first the I-21.9. And in here, this documentation just supports the sequencing, telling us the default for unspecified acute myocardial infarction or unspecified type is that I-21.9. And that is what we have here. But let's take a look at all these other codes that we have listed in our options. And as you can see here, all these other codes list type 2 or other type of myocardial infarction or STEMI. And our particular scenario just lists an acute myocardial infarction. So even if we didn't know this guideline, this I-21.9 is matches more with the documentation that we have in our encounter. So that leaves our answer as A, big 21.9.
Well, coders, thank you, first of all, Miss Bianca. Well, coders, that wraps things up. And I just want to remind you to continue self studying the chapters within Chapter 9, Circulatory System. Study those guidelines. If you like the MCG manual, it's an easier process, I think. And you use whatever you need. You also can use your ICD-10-CM manual in the index as well as the tabular list. The guidelines are there. Now let's talk about homework. Okay, coders, it's time to review that homework. You can find the homework on the website. Just log on to www.amcicoding.com and click on YouTube course. If this is your first time here, this is where you should go. Go to that YouTube course, read everything on the page, read everything, scroll down until you find the syllabus, right? And when you click on that, you'll see the books, the required books at the top of the page, and you'll see just scroll down to your week. This is week 5 circulatory system. First thing you need to do, if you're in the Discord, go grab that handout, the PowerPoint to this lesson, to this instruction. And it's good if you want to revisit the playback, right? So go rewatch the playback. You can see it. It is on this green hyperlink. Click it, you'll see this, and find your week 5. Also, read and review those guidelines. Make friends with them. If you don't have it and you just prefer to look at it from the perspective of the actual CMS, you can just click this blue hyperlink and you'll see the guidelines for 2025. Or you can just use the MCG manual, right? Use your MCG manual. And if you don't have it, you can get it on this link. It's from the website. All right, number 5. We've got a reading assignment. And the reading assignment is Carol Buck's Unit 2, Chapter 5. There you go. And it looks like this. So Unit 2 has several topics. Just read only diseases of the circulatory system. That'll cut down on a lot of your time. Also, number 6, if you need to, we've got some extra lectures on your playlist. Click that green hyperlink and you'll see them here. Part 2 is the one that talks about the coding for acute myocardial infarctions. I highly recommend it if you need more. In fact, I recommend both to give you extra guidance on circulatory system. Number 7, from your MCG, you can watch the TAP lecture. So you click on your MCG, and this first or second entry in your table of contents of the 2025, just click it, and you'll see all of the TAP lectures. And here is circulatory system. It is a great lecture to show you how to annotate your ICD-10-CM. So some of you might say, well, I can't take that MCG. No, you can't, but you can take your TAP. You can tap the guidelines from your MCG and put it in your ICD-10-CM. Just saying. And finally, coders, if you want additional exercises in your Discord, you can find them. And it's after this week's class. You'll see about 20 extra questions. Do not hand them in. All right. So Discord, speaking of Discord, go ahead and if you haven't already linked your YouTube account to Discord and go in there and get started. You can find all of the resources on the left. And if you don't know what to do, look up. It will instruct you and guide you. Now, time for the survey. All right. So thank you so much, coders. Thank you for your time. Let us know how we did. There's a survey. I believe they're putting it in the handouts. We missed it last time and we got it this time. So if you complete that survey, it just takes a second or two. Not a second. Let me see. It's under 60 seconds. Complete the survey. Helping us helps you. It does. It really does. And one more thing, if you will, if you liked it, like it up. If you didn't, like it down. I need to know. Let me know. Okay, coders. So this is where, right now, if you can do it now, that'd be great. Thank you in advance. Now, just want to thank my team. I just want to honor you because you do the work. They do, coders. They work hard. They are the best medical coding team on the planet, and I thank you. And coders, I thank you for the work that you do. And remember, this journey won't always be easy, but you are capable and you are meant to succeed. So go study, go practice, and go be great. And we'll see you in the next session.
4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around the world. AMCI. AMCI. AMCI.